Welcome to Doctors on Call. I'm Jenna Miller. Cardiovascular disease is the leading cause of death in the United States, and more than 800,000 people have heart attacks. Every 40 seconds on average, an American will have a stroke. What is the role of heart disease in the coronavirus? We'll learn more about cardiology and tips for having a healthy heart on tonight's Doctors on Call with our guest, Dr. David Battin.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from Gove County Medical Center in Quinter, healing through caring. At Blue Cross and Blue Shield of Kansas, we're committed to being a healthcare partner you can turn to. That's why we're simplifying the health insurance experience so you can feel more empowered in your health.
Regional Hospital, experts, neighbors, friends.
Dr. David Battin received his medical degree from the University of Kansas Medical School. He completed his residency at the University of Kansas Medical Center in Wichita and his fellowship at the University of Tennessee Health and Science Center in William Beaumont Hospital. Dr. Battin is board certified with the American Board of Internal Medicine, Cardiovascular Disease, Nuclear Cardiology, and Interventional Cardiology. He's a member of the American College of Cardiology, Society of Cardiovascular Angiography and Interventions, and American College of Physicians. Dr. Battin joined the Mowery Clinic in Salina in 2010. Our phone lines are open at 800-337-4788 toll-free if you have any questions regarding cardiology on today's show. Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you so much for joining us. Before we get started, you have a couple of little ones at home that are needing a shout out, I believe.
Yes, I have to say hi to my 4 boys, Mason, Knox, Lehman, Reese. Hello, boys.
They'll appreciate that. So let's get to some of the questions here. First of all, let's talk about how does a person know if they have heart disease or if they might be in jeopardy of that?
Right, so I think the more obvious thing is anybody with exertional type symptoms that are new or worsening would prompt an individual to seek medical care, such as shortness of breath with activity or chest discomfort with activity. Would be highly concerning for cardiac problems. You couple that with things that we call risk factors such as high blood pressure, diabetes, or elevated cholesterol levels, which would certainly increase your risk for having heart disease as well. In asymptomatic individuals, it's really teasing through the process of what's your age, what's your gender, what's your family history. What are your risk factors that we've previously discussed, and kind of putting that into a risk factor assessment, a scoring system, a calculator, so to speak, that many societies have put together, such as the American College of Cardiology, and determine what is your 10-year risk based on those numbers of having a heart attack or stroke, and then how aggressively should we treat those risk factors from a primary prevention standpoint to kind of mitigate your risk of having a heart attack or stroke. And when I talk about primary prevention, I'm talking about individuals that have not suffered an event yet. So that's really an important demographic.
Absolutely. How is heart disease actually diagnosed?
So there's a number of ways to diagnose heart disease. First of all, when you speak of heart disease is a group of disorders. It could be diseases of the valves, it could be diseases of the blood vessels, of the heart structure and function itself. So there's going to be lots of different modalities to do that. And depending on the types of symptoms that one is experiencing would kind of dictate what studies would be warranted. Non-invasive studies such as stress testing would be designed to, more of a functional assessment. Structural assessment would be something like an echocardiogram, where we use sound waves to look at the heart muscle, how it squeezes and how the valves are opening and closing.
How does high blood pressure relate with heart disease?
So high blood pressure would be one of the common risk factors that individuals have that would contribute to different disorders of the heart, such as heart failure, heart attacks, or strokes. So it's an important risk factor that we can treat to reduce individuals' risks of having those problems.
And how does a person go about lowering their high blood pressure?
Well, the simplest thing to do, well, I don't know if it's the simplest thing to do, but I should say the one that doesn't require medication would be weight loss and exercise that truly can impact somebody's blood pressure and bringing it down. Addressing other risk factors such as sleep apnea, obstructive sleep apnea, if someone, that's going to have its own set of signs and symptoms, but treating that can help lower people's blood pressure. And then, of course, medication.
Okay, we're going to go to the phone lines now. We've got Julie on the line from Junction City. Hi, Julie. Go ahead with your question for Dr. Battin tonight.
Hi there. Both of my grandmothers had complications from after shoveling snow this past winter, when my grandma ended up having a heart attack and the other ended up having a stroke, and then it took her life. I was wondering what it is about shoveling snow that can cause this.
Yeah. So when you're in, first of all, it's usually an extreme as far as the ambient temperature, and you're moving from a temperature 70 or whatever you keep your residence at, and you're going out into the cold, so you're shifting ambient temperatures. And then when the act of shoveling snow changes from aerobic to anaerobic very quickly, so your heart rate and your blood pressure are going to go up very quickly. And sometimes the cold air, breathing in the cold air, you can't really discern if you're having chest discomfort or pressure or shortness of breath from the act of shoveling snow or from just the cold air itself. And it's really that kind of rapid rise, or that, all those things together create what I would describe as a perfect storm for either a demand mismatch phenomenon, meaning the heart's not getting enough blood flow really quickly, and it needs a lot more than what the demand is calling for, and it can precipitate a lethal arrhythmia, or it can precipitate plaque rupture. So I think it's a lot of those extremes that come on at once that are really problematic, and our inability to sense that something bad is happening.
Interesting question. Who is not a candidate to be out shoveling snow? Let's talk about that.
I most of my patients are not candidates to be out shoveling snow, to be perfectly honest with you. I think you have to have been revascularized, certainly within a year after a stent, and if it's beyond 5 years after open heart surgery, you probably shouldn't be. And this is within the confines of regular medical care and adequate blood pressure control, and making sure these other symptoms aren't present. But once there's a lot of patients that if they have mild to moderate disease and we get them revascularized, they can go back to doing whatever the heck they want to do. So it's really knowing your patients and knowing what their heart looks like, and you can kind of individualize that and tell somebody, look, you just shouldn't be doing this. You need to get your neighbor kid to come do it.
Absolutely. Okay, we're going to go back to the phone lines. We've got Pat on the line from Codell. Hi, Pat. Go ahead with your question for our cardiologist tonight.
Yes, my 88-year-old mother had a heart attack in November, had 2 stents put in, and was told after that she should only be lifting 10 pounds. Now, that was in November, and she is wondering if she can lift more than 10 pounds now.
Yes.
Thank you.
Yes. I'm not going to waver on that one at all. Yes is the answer. The reason the lifting restriction was placed, and allow me to guess on behalf of that individual, but so the access site is usually going to be the wrist artery or the femoral artery, and we really don't want that site to bleed, okay? because we're placing a tube inside a blood vessel that's under pressure, and that artery needs to heal. So that's really the key. So the lifting restrictions are for the access site, the point of entry, where we put the sheath to do our procedure. And that usually lasts for about 3 weeks. And after that 3-week time frame, the lifting restriction is gone from a stent standpoint.
Okay, we're going to go back to the phone lines. We've got Irene on the line from Smith Center. Hello, Irene. Go ahead with your question.
I want to know about white coat syndrome. I have it.
Yeah, so very simply, it's there's a pretty high propensity of individuals that when they come into the doctor's office, their circulating neurohormones just get kind of fired up, and it makes your blood pressure go up. And it's really not reflective of your day-to-day blood pressure. And so in those individuals, and I say in my patients, I treat all of them like they have white coat syndrome. And so when I'm managing blood pressure, I want them to keep a diary of their blood pressures at home when they've had a chance to do nothing for 15 minutes and not be impacted by coming off the street or the anxiety of seeing a cardiologist or whatever, the stress of the day, the work, etc. And that way I have a more accurate reflection of what your resting blood pressure is. And so it like I said, it's really just kind of your body's reaction to having to go and sit in the doctor's office.
Do good blood pressures differ from person to person? You always see those numbers of where it should be, but can some people just naturally have a higher blood pressure than others?
I mean, so the national standard is the national standard, and I get that a lot, that my blood pressure just runs high, and the answer is no. We have a goal, and we need to treat to that goal. And really, what we've learned is the lower the better. The downside to that is you start ending up with a lot of side effects from getting it to that level, because it's going to ride a sine wave, so you're going to have peaks and troughs, and sometimes during those troughs, patients get a little bit, more than a little bit, sometimes uncomfortable with the numbers or how they're feeling or the side effects of the drug. So it's not always easy to get to that 120/70 number that seems to get pushing more and more towards the low end.
Okay, we're back to the phone lines. We've got Carol on the line from Oxford. Hello, Carol. You're live on the air on Doctors on Call. Go ahead with your question.
Thank you very much. I was just curious if they're making any advances in recognizing that women have heart problems the same as men.
I can tell you that the awareness campaign is as strong as ever. Our national organizations are always pushing that. The education materials that I see come forward from our national organizations, the women in cardiology, women in healthcare, they're all very much out in front of it, and I feel like the organization is doing a good job, and I think it's just getting it out there and just increasing awareness and education, and eventually we are closing that disparity, that gap. It's not where it should be, to your point, but I think it's better, and I can see that every year.
Excellent. We are going to go back to the phone lines. We've got Darlene on the line now from Claflin. Hello, Darlene. Go ahead with your question for Dr. Battin.
Yes, I had wondered, recently I have had palpitations and irregular heartbeat, and then my heart was just like beating out of my... Yes, I recently have had a palpitations and irregular heartbeat, and then I have had it was like beating out of my chest and felt like somebody was sitting on it. So I had talked to my provider, and he said that he would, evidently I'm going to have a stress test. Is there anything else that I should do?
Well, I would recommend a heart monitor for sure, since it seems that you were also concerned about the palpitations, the irregularity that you were sensing in your heart rate and also your heart rhythm. And so I would do that as well. If you're having them every day, a 24-hour or 48-hour monitor would be all that was necessary if it was that reliable. Lots of individuals with palpitations and similar types of problems that you're describing don't have them as frequently. They have them once a week or once a month or whatever, and so you may require a 30-day monitor or even longer monitoring. It just depends, but yeah, I definitely think you should have a heart monitor.
Okay, we're going to go back to the phone lines. We've got Zelly on the line. Hello, Zelly. Go ahead with your question for our cardiologist tonight. Are you there? Oh, we may have lost that caller. Okay. Well, let's talk about the difference between women's symptoms and a heart attack compared to men's. Are they different or are they generally the same?
By and large, they're going to be the same. I mean, women have angina, men have angina. But there are more of the uncommon symptoms with women. It may be perceived more as a shortness of breath or nausea, for example. So there's definitely some disparity, and you have to recognize that disparity. But most people are going to have chest pressure, chest tightness, some sort of sensation between here and here that is abnormal. New or worsening comes on with activity, gets better with rest. That would be kind of the stable symptoms. Anything that comes on abruptly, lasts longer than 15 minutes, you just got to go to the ER.
Can anyone of any age have a heart attack?
Yeah, I mean, the youngest I've seen is in their 20s, and I mean, that is, a sobering reminder of our mortality when you see that. So the short answer is yes. It's super uncommon to see that for sure. Younger individuals don't tend to have the same kind of problems, and certainly if they're not smoking cigarettes or have really high cholesterol levels or these other issues that tend to travel with it, but can happen to anybody.
Okay, we've got Gary on the line now from McPherson. Hello, Gary. Go ahead with your question for Dr. Battin tonight. Oh, Zelly's back. Okay, first we'll go take Gary here in a moment. Right now we've got Zelly back on the line. Hello, Zelly. Do you have a question for Dr. Battin? Are you there? Oh, we must be having problems with that caller. All right, so I think we're going to go and try Gary now from McPherson. Hello, Gary. Would you like to ask a question to Dr. Battin? Gary, are you there? We may have gotten our lines mixed up with taking that first call. So, Gary, if we lost you, go ahead and call back. Same with you, Zelly, so you can ask a question for our cardiologist tonight. You mentioned cholesterol. We were talking about how to lower blood pressure. What's good ways to lower your cholesterol?
So if we're talking about lowering our bad guy cholesterol or the LDL, two ways there are either to take medication to get those down or drastically alter your diet. The bad guy cholesterol, the LDL remnant, doesn't have a biological function really. And it as we mature, it tends to get a little bit more difficult to eliminate. Exercise alone doesn't seem to work. Diet, again, unless it's fairly extreme, doesn't seem to work all that well. But it will work, but you have to become vegan-like. That's the kind of extreme I'm talking about. But there's an array of medications to lower the bad guy cholesterol. Triglycerides, diet and exercise definitely works in lowering that number, controlling diabetes, and of course medication.
Okay. We're going to try this another time. This is Zelly on the line. Hello, Zelly. Are you there for your question? No, never mind. Okay, well, we'll just keep trying. So I know they're waiting to get their questions in before the end of the show here. We were talking before in the open how, there's more than 800,000 people every year in the United States that have heart attacks. Right now we're dealing with coronavirus, which is, I think, attributed to the death of a little over 40,000, I believe we're at right now. But then we have, people who die of heart disease, that's well over 600,000. So let's talk about that and how we can lower that number.
Mm-hmm. Yeah, so, lowering that number really is about identifying the risk factors that contribute to heart disease and attacking those risk factors. And if I had a list of 10 things to do, 1 through 8 would be to not smoke. Don't smoke, don't smoke, don't smoke, don't smoke, period. It's the most powerful thing any individual can do to lower the risk of heart attack, stroke, heart disease, you name it. And then after that, it's really about identifying the other risk factors that contribute to heart disease, such as high blood pressure, diabetes, high cholesterol, weighing a little bit too much, sleep apnea, etc. And attacking those things to really eliminate future events.
Okay, Gary, are you there? We're ready to take your phone call. If you're there, this is Gary from McPherson.
Yes. Hello, doctor.
Hi.
I'm just wondering what your thoughts are about treating AFib by adjusting your electrolytes. For instance, cutting your sodium way down, raising your potassium way up, adding some magnesium, and maybe upping your calcium.
Yeah, I wouldn't really consider that treating your AFib, to be perfectly honest with you. I think that, AFib is a complex rhythm disorder. It's super common. It's going to become more common as we mature. It's really one of the principal causes, kind of some age-related changes of the heart and different risk factors that come with it. And the principal thing that we need to think about when we're talking to patients and managing atrial fibrillation is what it does to their stroke risk. And depending on how many risk factors that they possess, really kind of dictates what their annual stroke risk would be. And so you get into a conversation about preventing stroke or preventing a systemic embolization. AFib can create a scenario where there is static blood flow and you can get clot formation most of the time in what's called the left atrial appendage. It can be ejected from there and travel anywhere in the body. So being on warfarin or Xarelto or Eliquis or what have you would be a discussion with your doctor based on your risk profile about stroke prevention. And then really it's rate control or rhythm control, and it comes down to how symptomatic is the individual. And having optimal rate control is super important. And then, whether or not you make a decision to try to go back to sinus rhythm really is dictated on what kind of symptoms the individual is having. While having a kind of, normal static or homeostatic electrolyte balance is important, it's really not going to alter the AFib as far as management is concerned.
Okay, let's get back to the phone lines. We just got a few minutes left here. We've got Zelly on the line now. What's your question for the doctor tonight?
Hi, what foods are good for my health?
Can you repeat your question?
What foods are good for my heart?
Foods that are good for her heart.
Oh,
Yeah.
Foods. All right, there you go. Sorry, you're kind of cutting out. So, so when we talk about, heart healthy diets, this has been looked at, a fair amount over the years, and it's really difficult to kind of control for different diets. But I think in general, the Mediterranean diet or heart healthy diet consists of more fruits and vegetables, nuts, more white meat and less red meat, more of the fish and chicken and pork and less of the beef, and then whole grains, less refined grains would be, considered heart healthy.
Okay, we have under a minute left, but we've got one more caller waiting to ask a question. So this is Susan from Sylvan Grove. Hi, Sylvan, what's your question? Real quickly.
Yes, in September I had symptoms of a heart attack, and I had a abnormal EKG, an abnormal sonogram, an abnormal stress test. They went ahead and went in and looked for a blockage. There wasn't any. They decided that it was not cardiac related, but I'm getting no answers on what has caused the heart to look abnormal on the other tests.
Yeah. Well, you can always get a second opinion if you're concerned about those questions and you're not getting the answers that you're looking for. Unfortunately for me, telling me that it's abnormal can mean any number of things, and it's not any one thing that I could say that would necessarily be helpful to you tonight for sure. You know, an abnormal echo, I don't know what that means. Is it the valve? Is it the heart function? Is it the squeeze? Is it the pericardium? I don't. There's just way too many variables to kind of, you know, peel back that onion.
Okay, second opinion might be a good
Yeah,
option.
I think the second opinion, if you're
Absolutely.
unhappy.
Well, our thanks goes out to Dr. David Battin from the Mowery Clinic for being our guest. On our next Doctors on Call, we'll give you an update on the coronavirus. For Doctors on Call, I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from Gove County Medical Center in Quinter, healing through caring. At Blue Cross and Blue Shield of Kansas, we're committed to being a healthcare partner you can turn to. That's why we're simplifying the health insurance experience so you can feel more empowered in your health.
Russell Regional Hospital, experts, neighbors, friends.